طيب السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. First of all, thank you very much for the kind invitation. It's really a pleasure to be in Yombo after 10 years from the last time and in the Royal Commission for the first time. It's really a pleasure because I have many, alhamdulillah, of my colleagues. They are Sibahi surveyor in Royal Commission, so I see you in your facility. To clarify one thing, today I'm presenting myself, so it's not Sibahi presentation. Though I'm willing with my job description to answer any of your queries, but out of my presentation. So today I think that I'm just going to complement whatever said in the last two presentations regarding the role of the leadership. And the concept is the patient safety. Concept is really how to embed the quality and the patient safety as part of our daily work rather than to prepare for it. To go with Dr. Ahmed, that really, and Dr. Fayoumi, really this is the thing that we really need to exclude it from our agenda to prepare for the accreditation. Because I can assure you that will not continue, especially if we are working and talking about the unannounced visit. So if you are doing this on a daily work, it will be like a byproduct. You don't need even to know when the surveyor are coming. Though that there is nothing about the accreditation that I'm going to talk about it specifically. I'm not going to talk about Sibahi. لكن طبعا ما أقدر. I have to say something at the end. We will have like plugs today. It's the 6 plugs. First is the magnitude of the problem, and who are the leaders, what is their role, and then I'm really taking from this presentation guided by the IHI published paper in 2006. It was about how it's a guideline, and I call it a short prescriptions for our leaders. It doesn't mean the leaders on the hierarchy, and now we can even define who could be the leaders in the hospital, and then how to develop your skills and what is next. Please, when we start, all of you, as a leader, I don't want to say starting from Dr. Fuad, all of you, please think about if there's serious event happened with you, and how did it go with the patient family, the staff organization, or with you. And you were surprised when you have this event, was it something unexpected? So think about it when we are going through the presentation. How is the magnitude of the problem? Definitely, when we all talk about the quality and the patient safety, we all talk about the error is human. Nobody doesn't know about these numbers. Do you think since 99 that we are really improved? Yes, no? Showing hands? Yes, no?
In the middle.
The only thing that we can maybe assure that the reporting is increased. So the number of the incident could be increased because of increasing increment of the reporting, or because there is an incident more. This is actually reported in 2017 by Canadian Patient Safety Institute that the preventable harm occurs every 1 minute and 18 seconds. So this is really very scary. And then we have a patient dies from patient safety incident every 13 minutes and 14 seconds. God knows what's happening in Saudi Arabia, because still until now we are initiating and starting now the reporting system and to be in actually comply between all the healthcare facilities. It started by the MOH and the private hospital. Still we miss some of the healthcare providers like the University Hospital or National Guard, but this is a fact at least internationally. Now let's talk about the leadership. Usually it will go with the hierarchy with the same names. And I put in the middle the clinical leaders because they are the most difficult people to deal with them. Right, Dr. Fuad? Especially لو كانوا جراحين. Saying this, you have the way to deal with them. You have to respect many things for their challenges because they are dealing directly with patients. Same as the nurses who are the patient is between their hands. So if you are in the supply chain, just consider that they have somebody who's dying in their hands. So think about this one to consider why they are difficult. Because of their patient, because of the risk that they are focused. They are well-trained category in the healthcare, and they used to be to work on their autonomy system. But when we talk about the definitions, there are many definitions, but we can choose this one. Those who can productively direct the efforts in their healthcare organization. So not necessary to be on the top of the hierarchy. And you can see that there are many leaders, maybe they are not even on the top of the big box in the organization chart, but they are the leaders because they can affect the productivity. foster the culture and commitment required to address the fundamental system causes medical errors and harm to patients. I can say that there are many, if we take an example, especially for example the cleaning, the hand hygiene, or the infection control, you will find our colleagues from the housekeeper, they can really enforce this. They can really work to make sure that the cleaning of the different area with a different high risk area, those are the people who can lead preventing the error in those areas. It doesn't matter that they have to be on the organization chart. Now, if we talk about the styles, I know that you know better than me about the different styles of the leadership. Definitely, we don't need to have only one title or one definition of this leadership. Now, if we talk about transformational, which is now, it's really necessary and needed for this stage that we have it. So those people, I can just simply define them who are in a position that they can actually put the inspiring vision for all the organization, and they can communicate it from the C-suite to the sharp end. Please, as a leader, don't put your vision, don't put your goals separately from the people who are working in the front line, in the security, or even in the gate of the hospital. If you are doing this, I just heard it from John Maxwell yesterday, YouTube, if you are on the top alone, you are not doing the right thing, simply. If we talk about the transactional, who are the people can actually manage a task or make the orientation to execute the change. And then the autocratic, definitely sometimes as a leader we need to be autocratic, but definitely this is not should be the continuous style of the leadership style. But sometimes we need it, especially in the emergency, like in the fire or in the risk that can attack the patient or the staff. So you need to be autocratic maybe for a minute or for hours. This is a fair, maybe this is one of the things that people, they don't like it, all the people when they have it in the CPHQ. But sometimes you need to be like this. If you give the people the chance that they can they can create, they can imagine, go out of the box, but for maybe a time, and then you go back to the situation that it needs the leadership style. Task-oriented, definitely, they have to make, those are the people who can really put the action plan, they can make the clear orientation, clarify the objectives for the people according to their job orientation or job description. And then the relationship-oriented, who are the people they can amalgamate all the tasks or all actually the responsibilities under one task, make the team work together towards or to hit that one objective. Now the healthcare system and the leadership. We are really working with a very high risk system. We are working with a very complex system. We are working with different human beings from different backgrounds. Always we have a challenge, especially in Saudi Arabia. And before 2 days, I have a discussion with Dr. Hind Al-Sheikh. She's the president of the Public Institute in Riyadh. When Professor Ayman Abdu was talking about that we have a challenge in Saudi Arabia, at least we have like 40 different nationalities in one hospital, and those people coming from different backgrounds and schools. And she said this is similar as the one happened in States or in Europe. Do you think we are similar with America? Why we have a challenge with the different nationalities and different school and background? Because maybe there they have a well orientation program before they start their work or start touching the patient. I'm sorry, is there any echo with the voice or it's okay?
It's okay.
So the thing here that we are not expected in our healthcare system that we will have 100% perfect performance because of many challenges. There are a lot of complex services that we are using. So we are dealing with the patient from the front line and with the patient, and then with the care team, with the organization, which include all the infrastructure, not only the hospital, everything that's surrounded or actually related. And we are working, especially now, with a lot of challenges regarding the regulatory, marketing, and policy framework. Now, how many of you, especially in the Royal Commission, are aware about the changes, about the cluster happening in Saudi Arabia? Can I say raising hand? Excellent. So you are going to be part of those clusters. Are you going to be both? This is important because by any means we have to work together. Even if you are in one city, we are talking always. When we talk about each other when we have a disaster, right? This is the only thing that we put National Guard MOH, Royal Commission, and the military only in the disaster cases, لا قدر الله. Preparation to this, not always. Maybe we are lucky in Mecca and Medina because of the Hajj. But is this part of our daily work to work about the preparation for the disaster if it happened? لا قدر الله, I don't think so. Now, when we talk about the role of the leadership, first of all, they are the one who is responsible to shape the culture in the hospital, between the healthcare provider working with them, and even to reflect this or impact this on the patient and the visitors. To be accountable for an effective care in a system approach. So it's not department, it's a system approach. I really feel so happy when I really look at the hospital who is looking for a happy staff. Because for sure when we talk about, I think Ms. Leslie will talk about the happy staff, this is definitely it will be impact on the patient. You can feel it. I'm saying, when I have to say this to Dr. Fuad, I'm saying that your driver was very loyal to Yambo, and I'm sure that he's loyal even to the hospital. This can reflect the culture. يعني I'm sorry to say في أحد من الخطوط السعودية هنا واحد يقرب له واحد from Saudi Airlines. I'm always talking. Half of my family working in Saudi Airlines. If you go to the airline and you found something broken and you found the guy there told you that, I'm sorry, well, and I called the maintenance في الخطوط السعودية, but they didn't respond to me. It's not my business. Until you are one organization. If you go to a hospital and they said in the front line, what can I do? This is the mudir order. What can I do? How do you think this is the culture? They are completely separate from each other. Somebody on the top in the ivory tower put the instruction for people who doesn't have even the resources to help the patient. And then you will contract a consultation company to measure the patient experience. For God's sake, why? Just go from inside. أنا عملت عاملة هذا حبيب الكل, James Raisin. We are all think about him when we talk about the quality and the risk management. So he said that the system approach is not about changing the human condition, but rather the condition under the human works. Now, as a leader, I'm sure that this is kind of our always dream. This is the mindset that we have to think about it as a leadership. If we think about this Swiss cheese model, and could be in our mindset, I'm sure that we will avoid a lot of risk. So you have to focus on how you can help the hospital. When you put the strategic plan, part of it is the safety goals. And when you put the safety goals, focus on what are the challenges and what are the enablers that can help your staff to do it. So don't say that we need to have the best patient experience while you don't even delegate any small authority to your frontliner. The safety officer or the security guard will not allow the person coming on a wheelchair to enter with his car inside because this is the order of the mudir. Do you think that we are thinking about the Swiss cheese model? So this is put it in your mind how you can make sure that this movement will pluck the error, the harm, the mistake to reach the patient or the staff or the visitor. So think about the experienced team members, well-designed, designated communication process, and strong supervision. And then communication, which I like this term that I learned maybe 3 months or 4 months ago, from the C-suite to the sharp end. If you are not doing this, so you are really breaking the communication channel between you and the frontliners. Now, this is the leadership guide to the patient safety, which it's really a wonderful references with a lot of tools there that you can even enter and you can even download it for free if you want to use it. I call it the short prescription for the leaders that we can do it on a daily basis, and it will avoid even preparation for the accreditation, hopefully to avoid the stress and make Dr. Badri happy and all our colleagues happy. It's an 8 steps that we can go through them quickly. The first one, address strategic priorities and infrastructure. So we'll go to the first one. First one, you have to make all the strategic plan embedded, the patient safety goals. This is part of the strategic plan. And definitely this will be cascaded to the action plan, to the operational plan. So it's from the C-suite to the sharp end. Then we have to put an indicators, use the data, use the numbers, and the valid or validated data. You know, that the numbers, and I like the KPI slide. It's strange, you know, Dr. Nashad, that this slide I don't know why people they are sending this to me. Over the last week I received it 5 times. مع اني والله ماني مسؤولة عن أداء. لكن I received it. But this is one of the things that we really have to think about it, that numbers really can cheat a lot, can mislead you. So you have to validate and make sure that the data is really coming to you from the right source. Then put the action plan based on this one. Then actually escalate this to the board meetings, put it in the board meeting minutes and the agenda, discuss it and follow up for this one. Then when you have any success stories, please spread the word between your staff. Make sure that they are very proud about this one. Even if a mistake happened and you have an action plan to prevent the reoccurrence, so again, spread this mechanism or action that you do it or you did it, so people they can learn from each other. I'm happy that Dr. Abdelilah was here, Dr. Hausawi yesterday, because they are working now to make, inshallah, patient safety alert. The most important thing from reporting sentinel events is to prevent the reoccurrence, which until now we don't do it, like inshallah it comes. Assign executive to safety performance improvement team. I'm going to ask who is the best person maybe to put him in the executive, in the quality team or patient safety team. شخص دكتور أرشد وذكره. Financial controller. Put him inside those team. معانا؟ في أحد معانا؟ أهلا وسهلا. So you will be assigned for one of the patient safety team. Staff orientation, this is important again, not only about the original or regular one, but they have to know about what the incident could happen and how can you prevent it. So this is the senior leadership team. Definitely we have to assess the organizational culture, and I think now, alhamdulillah, most of us, we have this experience, especially with the accreditation introducing the patient safety assessment culture. We are using mainly the AHRQ, but you can use any one of these. But you have to make sure that you are avoiding the blaming culture, again, the autonomy among clinicians, lack of teamwork, lack of transparency about the medical error. We will talk about this in the next slide, and the poor communication. The patient safety culture assessment is really a good tool to know exactly where is it, and I can maybe encourage Dr. Fayoumi and Dr. Badri, maybe you can do some of the research regarding this one, because this was my doctorate. You will see that the accreditation, it's one of the tools that can really improve the patient safety culture. There is one paper, I can share it with you, in 2017 published, that can show that there is a direct effect of the accreditation in improving the patient safety culture. When we talk about establish the culture that supports the patient, definitely this is the key word when we talk about the team. So what if we are talking about the culture? The trust is, this is really, it's gained, and our staff or our colleagues, they are testing the leadership. If we say that now we have to have a communication medical error, and we want to make sure that we disclose it clearly and no blame culture, and then the first thing that I'm going to punish the person who I'm going to pinpoint that you are the one who is responsible. I think we are now become mature enough professionally to know that the error rarely to happen because of what somebody. It's a system failure happen that lead to an error. So now we want really to spread this culture and to make sure that people, they understand this one. Sustain the self-disclosure of the medical error, and again, here, sustainable the just culture. When we talk about just culture, people, they thought when we move from no blame culture to just culture, it means that we want to make everybody is accountable. Definitely is everybody is accountable. But when we talk about the just culture, simply, we want to discuss the error in a very clear manner with a transparency and make sure that we are saying the facts without assumption and without talking to the people who were not involved in the incident. This is the ABC of the RCA. So this is just culture, and then we talk after transparency, we communicate with the people who needs to know about this one, whether the patient, the family, the staff, whomever is really involved. Share the analysis of the report, definitely with the clearance, and reward the middle manager. I think there is a good approach, maybe you have it here in the MOH with the good catch, and they are really celebrating about this one. Establishing a reliable process, this is again very important to make this as really repeatable with the right thing and improve. Address the organization infrastructure, and I can say that part of this is really good because I'm so proud that I say that the accreditation standards enforce this in our hospitals. I'm there since 2001, and I can understand when we started even in the MRQB, many of the hospitals, I can say more than 80% we were visited, there was no any committees. There is no quality directors or quality officers. Though I'm always saying, and my objective is really to manage the quality department. So دور دكتور فيومي أنا وأنت على position تاني. لأنه it's really everybody's work. It's everybody's work, as you mentioned, that everybody needs to be there. So sometimes we need to have a guideline. So the accreditation standard could be one of this. The PSO, the patient safety officer, I know that, or I'm sure Dr. Hausawi mentioned, now there is a national initiative to have even an academic training for a patient safety officer in collaboration with Saudi Commission and between the Patient Safety Center. And we talk about the teams and the committee. So this is the infrastructure that we can talk about it. Learn about this patient safety and the method improvement. You can select whatever improvement method that you want to adopt it. Let everybody to know about it. Educate the senior about how they are using it and what will be the end result. So they will be involved and they want to understand the results and the report. There is one standard in our Insibahi standard that we have to have a qualified staff in the quality department, and the leaders, they have to know and read the report. So when I have, for example, a QC, or I give any of the charts to the CEO, and the quality director there, he's smart enough, mashallah, and you have a lot of smart people, not only the quality, those numbers, if I don't understand how to read it as a leader, it can mislead me. So make sure as a leader to understand exactly what does it mean of the QC, what is the upper and lower limit, what does it mean if I have like a special or common cause. This will help you to discuss even with your staff or with the team. Rely on the frontliner staff ideas, please. They are the best people to listen to them. They are the one who knows the challenges and the enablers that they can help them to do the work and to implement or to execute your goals and your strategic plan from the top to the down. For example, if we talk about reducing the hospital-acquired infection. Now, Dr. Fuad, he put, for example, that part of it in the infection that we want to reduce the HAI, VAB or whatever, to 30%. Do you think that he's the one who will go and teach the people in the ICU how to do it, bring all the tools that he will do it? So people, they have to be, there's some authorities that need to be delegated, resources has to be there, training for the staff. So this is how you can just make it from the top to down. But definitely the challenges would come from the frontliners. As I mentioned, maybe this is, and I put some slides that only for reading. When we talk about the model of improvement, we have to be very clear regarding the question that we are using. What are we trying to accomplish? If you go to any meeting without clear objective what you are doing, I'm sorry, please leave. Because we spend, and I know يعني معلش أنا أقولها بالعربي, sometimes لما نقعد 10 أشخاص لمدة ساعة, يعني نتكلم مثلا في, خليني أقول حتى بنقعد 10 دقائق ونقعد نتكلم مع بعض في حاجة إحنا ما إحنا عارفين ليه جايين. يعني حلو لو نشرب قهوة, بس حتى ممكن نشرب قهوة بأوبجيكتيف معين. So I'm not saying leave the meetings, but please put an objective and agenda, clear agenda. By the way, sometimes it happens on a very top level that you go because a very nice invitation in Ritz-Carlton, and then you go and back and you said the coffee was very nice. Have it happened with you? I'm sure.
Not in the Ritz.
And then for the PDCA, أنا والله نفسي أرجع الرياض صدق. By the way, and I said Ritz-Carlton because this is one of the best hotels in Saudi Arabia. Step 2 is engage the key stakeholders. Definitely engagement is the key word between the senior, the leadership, the physician, and all the stakeholders working with you, then the patient and family. I'm sure that there are many committees, especially for the patient family rights, they are involving the patient or their families on the committee, and I think the patient experience, you have to make sure at least that the patient or the family, they are involving with you, so at least you can hear from the others or actually the customer that you are targeted. I like this one that we believe in numbers, but the patient story is really one of the best. I'm so proud in Sibahi that when we have the ESR or the patient safety culture, the essential safety requirements, we are talking about the stories behind the scene. Why did we select the ESR? And really, this is the most important presentation that I ever had when I presented, because you know what? Many of these stories related to our colleagues, people who work with them. So the stories can let you know exactly what was the risk and how it's really harmed, because they were some of our family. Engage the stakeholders. As I talk about the board, you have to educate the board of their responsibility. By the way, this is part of our standard, so you have to make sure that they are educated on the level, so don't take them to the details, but let them to be aware at least when they received any reports. Ensure the integration of them as part of the organizational strategies. So when they are talking about the plans, they have to understand exactly the root causes, what are the contributing factors, and then structure the board agenda so the quality and the safety are given at the same amount of attention of the financial issues. فاهمة؟ This is very important. Sometimes you will spend the whole, what if we're talking about the patient safety and how is the financial support will help with this? This is again, both of them are important, but we are working for a patient. So this is the most important targeted that we want to have it is the patient safety and the staff safety. Engage the key stakeholders when we talk about the physician. This is very important, and we have the physician champion. I'll tell you a very short story, and I'm so proud of one of my colleagues, Dr. Taha Zamani, is a consultant orthopedic surgeon. أخويا وأفتخر دائما أتكلم بيه. Once I started in King Fahd Hospital talking about the patient safety goals. يعني احنا اصحاب لدرجه قال لي بلاش الكلام الفاضي والرغي حقكم هذا، ودائما يقول لي بس انتوا تتكلموا في الكواليتي، وهذا شغلنا، انا ذاك العيشنا صح؟ نتكلم كثير. والله انا I wouldn't say that how much ما شاء الله دكتور طه سمان he was the best patient safety advocate in the hospital. He became the chairman of the patient safety committee and even for the patient safety goal team. Why? Because he faced this with his son Adnan. MashaAllah, he's a doctor now. And now when you convince the physician, they become the best advocate for your patient safety goal. Let them to be in. Give them exactly what they can do because of their patient. Support their needs and support their patient care plan that they are doing. Empowerment of the staff. Definitely this is a key word again. By trusting them, listening to them. If you have any, for example, if they give any idea and you feel it doesn't work, please don't hammer them. Maybe there was something happened wrong and you need maybe to change it. So give them the chance to think out of the box even. Let them to participate in the decision making, support by coaching and mentoring, inspire all the staff to work as a team. Actively promoted the achievement of the team and foster the teamwork. Make sure that when you decide about the team, simply that you draw the high level of the flow process and then you select the team members. It's not that you select the people on the organization chart. Definitely this is not only a traditional way, this is the wrong way to choose the people for the teamwork. It depends on what is the process, so who are the people who is involving in this process. Then for the patient and the family, definitely we have to make sure that we appreciate them. We appreciate actually their ethnic and identity. Make sure that we respect the culture and the literacy level. Yesterday they were talking about that there are some, and one of the burger shop, that they are actually trying to talk in English or speak in English with the people. Why? You want to show that we speak English, and at least we know vocabulary. So we want to make sure that we have the language that people can understand us. And you make sure that the frontliner, they can really communicate. And I'm so proud that before, maybe in 2004, when I was preparing something like this in the hospital I used to work, one of our security guard, he was really so kind. He said, what about the special needs if they cannot actually hear us? Who will be? Because the accreditation standard, they request to have a list of the different language. So what about our family members if they are actually challenging this? So those are the frontliners who actually meet this kind of difficulty or challenge. Support the concept of the patient-centered care, which I'm sure that my sister, Dr. Ali, yesterday she talks about it. Documented the care plan and involve the patient with you, please, because they are the one who you want them to cure. If they don't know exactly what you are doing to them, if he doesn't or she doesn't know about her medication, if she doesn't know what exactly to do after the discharge, so what we are working for? No, we didn't say that we need them to take the decision clinically, but we need at least to let them know exactly what will happen to them. And by the way, sometimes it's not only for the patient who maybe can good level literacy. It happens with you if Dr. Fuad and أخويا. If Dr. Fuad now go to King Fahd Hospital, they will treat him in a different way. But maybe you will go home and you don't know exactly what to do. And it happened with me. I have a surgery. When I go, wallahi, I don't know exactly what I'm supposed to do for the next 6 hours. Because everybody was taking care of me, but I don't know what they are doing and what I'm supposed to do later on. أبو علي أنت دائما بتسميها إيش؟ Hyperrecomendoma. Yeah, this is another disease.
Recomendoma syndrome.
Again, the team has to know that the disclosure of the error with the transparency, this is one of the values that we have to adapt it in our hospital. The step 3, communicate and build awareness. This is again very important. We are talking here, there are many details regarding the leadership walkarounds. Now, it can be structured with a format, but the thing that you need later on to go for the details that you have it, analyze it, and take an action and involve the people who are with you. In the walk around, you don't need to talk in a formal way, but you need to discuss the patient safety only. So don't discuss the punishment for people or even attack them. Just go with the vision that this is a patient safety round. Involve many of the leaders with you, not necessarily to be the head of, or the hospital director. It could be actually interchange between the leaders, whomever you feel that it will help. It should be in everywhere in the hospital, so in the clinical and non-clinical units, so you will find a lot of things that is really related to each other. For example, the supply chain and the ICU, the pharmacy and the store. So it's better to go, and sometimes the quality can help from the incident they have, how they can design or put the schedule for the walk-arounds. The safety briefing, now they are actually in this paper, they said that the safety briefing with the leadership walk around, it works very good to make the successful of the patient safety stories, because people, they need to know the step-by-step what is happening and what could be the action plan to support this. This will increase the staff awareness, empower them to talk, especially with the leaders, so they can really talk and share with you the information without fear. And review any safety-related topic before any new procedure. Again, this is one of the SIBAHI standards that we put, that you need to review it from two customer point of view, from the patient and the workers. So they have to pilot it, or you have to pilot it to make sure that it will be continuously running without any implications later on. Have a communication using a SPAR. This is not necessary to be, it could be anyone. All what we need is to have the structure, the standardized communication process among the team to make sure that we are ensuring the patient safety effectively. Now, as we mentioned, Dr. Najat said in the morning that we are learning a lot from the other industry, and one of the best references is the aviation and the nuclear weapons, but always we are talking about the aviation. So the crew resource management, this is one of the names or technique that communicate the methodology based on the team-centered decision-making system, and there are many ways. In this paper especially, you will have at least 3 or 4 pages with a lot of tools that you can utilize it. It's online and it's all for free. The step 4, to establish, oversee, and communicate the system level aims. So establish aim beyond benchmark. Now, we have to put an achievable goal. Let the hospital or your staff to work for them until they achieve it, then you raise the bar. I can give you the story that happened. You remember in 2004 when we talk about the saving 100,000 lives by IHI, by Dr. Donald Berwick, it was started. This is in the paper, they mentioned that 67% of the 3,000 hospitals, they were involved to implement the VAP. And then in 2007, Dr. Berwick, in one of the international conferences, he mentioned that 26% of those hospitals who participate in the VAP, they reach the zero of the VAP. So they go beyond even the benchmark, and this is what we need. Start with something achievable, then raise the bar, so you get the people to grow with you and according to your resources. Track and measure performance over time and strengthen the analysis. This is definitely very important to use the hospital mortality review. If we are not putting the mortality review, that this is part of the most reliable resource of data, so we are doing something different from the patient safety work. So use the data, analyze from there, and this is very important. The same as global trigger tool. This can give you an indication about the mistakes or wrong could happen. And then something like additional related to the medication safety, ISMP, they put a lot of references that you can use. When we talk about this, أنا هذكر حاجة about mortality. We are receiving a lot of sentinel event happened, and I'm sure that you are hearing about the sentinel event reporting to the MOH and now to Sibahi if the hospital is accredited. Before 2 days, I was reviewing the file that the sentinel event happened and we received it in Sibahi. What do you think if those sentinel events that we are only, this is something not officially, suddenly come to my mind, if we work only on a strategy to prevent this sentinel event from happening, and I can say I have this sentinel event this year, and then in 2020 I have 0. I think this is a tangible, achieved goals that we have it. So we have a kid that failed from the top of the hospital because there was no fence there was no cameras, there was no security, and alhamdulillah for 2020 we have no incident of this one. I think this is something that the people, they can really believe that what we are doing is reaching the patient safety and we are taking care of our patient. Improve the analysis of adverse event, definitely the RCA and the failure mode, which is like a proactive approach before this one. Both of them are mentioned in our standards. Strengthen the incident report mechanism. Alhamdulillah, I think now we have a lot of mechanisms to improve the incident report reporting, even now on a national wide. And SOTAC is one of the programs that we are very proud that we started, inshallah. And this, I think, will drive the alignment between all healthcare providers to have a learned lesson from each other to protect our patients. Support the staff and patient family impacted by medical error. So definitely when we are talking about the incident happened or the medical error, we want to protect the patient being harmed and the staff, the second victim. And we are all know about many heroes, and I call them heroes. If they report about an error, when I will mention this case, you all know about Rihan case, which happened in the Jizan with the wrong blood transfusion. I can say that Mr. Ibrahim al-Hakami, I'm his advocate now, the person who became really very responsible and came at the night and he said, I did a mistake, I bring the wrong blood and I give it to my cousin because they were from the same family, and then the guy now he's at home. And we open his subjects starting from 2019 to see how can really return. So the second victim has to be supported from the leadership as well as the harmed patient. Think about their staff, and they are working in a very complex system, and they are very harmed. I mean that they are working under stress, especially with the night shift or even with the long shift. Transparency with the disclosure, make sure that you disclose it. Okay, and less than this. Leaders' commitment, it's not only by talking, by standing here and talk that we are committed and we will do. سنبني لكم مساكن شعبية هذه خلاص it's out time في الموضوع ده. We have to provide resources, we have to listen to people, we have to support them. Align the system, definitely this is very important. The alignment is a key word that create alignment between the organizational strategy and with the improvement project with the national initiative. There are a lot of national initiatives now that we have to be aware about it and how to be part of this puzzle. Unify the quality plans and strategic plan, and this is again part من الستاندرد. على فكرة المفروض أنا كأني صرت advocate مع دكتور بيومي دكتور بدري. Ensure the daily work of the employee is organized and it's part of their work as a patient safety. Implement, monitor and revise the strategy as needed. ما في قرآن في الاستراتيجيات. Everything can be reviewed and revised and changed upon the changes that we have. Align the incentives. We can do this and align the incentives with the patient safety. The compensation plan. I'm sure that we have a compensation plan for the good catch or for the catching the error. Redesign the system and improve the reliability. This is very important. This is again, يعني هذا زي ما بيقولوا a platform for the reliability. And I can see that here you cannot go for this leadership commitment without having an accredited hospital. Because all of this really mentioned in the hospital, it's how to look to the standard. Is this an HRO or it's different? And we have now a collaboration between Sibahi and King Faisal hospital to how to embed the HRO concept within our new standards. By the way, there are many standards, you can label it, and this is an exercise that we can do it together. Definitely the rapid response team is one of the structures that is really help in reducing the mortality and saving the resources and the medical time. Introduce the simulation. Again, this is part of the aviation industry that we need, so people they can even try to learn before they go for a new process. Now develop your leadership. We finished the 8 steps, and now we go how to develop your leadership patient. Definitely as a leader, you have really to know about the patient safety, educate yourself, go for any science that will help you to be better patient safety leader. The other secret is listen, and listen carefully to your staff and to your frontliners. The other one, don't ever say that mustahil, it couldn't happen in my hospital. It could happen in your hospital while you are blinking your eye. You never know what could happen. Act as a real role model, definitely ready to celebrate the success and be approachable and visible. الكلمة الشهيرة حقتنا إيش سياسة الأبواب المفتوحة، هي كلمة حلوة بس المهم تكون مفتوحة to listen to people. As I mentioned before, I can't go without mentioning سباحة. It's in my DNA, Dr. Nasha. So just yesterday, we were working on some of the data that we will present it, inshallah, in December. We are linking actually what is the most affected factor to the results of the accreditation. You can see here the positive correlation between the medical relationship and the accreditation, how positive it is. This is a real data in 2018-19 from Sibahi data, the same as the leadership and QM to the accreditation. There will be a details, inshallah, in December, we will present it. So this is the end, and what is next? I can say that harm from error is inherent in our complex system, definitely. We will not go. We are trying to work to reduce it. Maybe you raise the bar to eliminate it, but again, we are working with a human being, with a very complex, that the error still is one of the inherited system that we are working on. The last thing that I put it here, I'm sorry, حطيت اسمي لكن أحتفظ بيها. The C-suite crafting the inspirational vision, drive the change. This is Michael Nees. And Majdah Shugdar قالت through the sharp end of staff. If we are not working with the frontliner, I think we are really separately من الرياليتي أو من الواقع اللي احنا عايشينه. شكرا جزيلا. There are a lot of references here. I hope that you will enjoy it later on if you want.